I can turn up the brightness.
Okay, go live.
Alright.
Okay. Hi, this is Elliot Fishman, and I'm going live. We have 10 terrific cases for you. Let's take a look. First case, patient presents with abdominal pain, and you see this enhancing lesion a little over a centimeter in the stomach. It's also very vascular. You can see it again as I look at the coronal views on the greater curvature and the MIP imaging. So then you ask yourself, you have a mass in the stomach that's small, but it's vascular. What could it be? Well, adenomas, polyps are typically not that vascular. Vascular things are neuroendocrine tumors, possibility, carcinoid tumors. Ectopic pancreas can occur, but it's more likely in the antrum and it's not that vascular. Metastasis, like from gastric cancer, are rare, but it can occur. AV malformations, but that doesn't look like an AV malformation. I don't see the feeding and draining vessels. So what are we thinking about? Well, it's only one lesion, and when I see one lesion, I'm kind of stuck with a neuroendocrine tumor. I'm not sure what else I can come up with, so when you ask me for the diagnosis, I'm going with a neuroendocrine tumor, which was the correct answer. Now, neuroendocrine tumors can be multiple sometimes, and that's commonly associated with syndromes like MEN1. Okay, let's go for the next case, GI bleeding. You look at the liver, there's multiple cysts. You look at the stomach, there are multiple filling defects in the stomach. What is going on? Well, let's look at it a little bit closer. You can see the filling defects are polypoid lesions. They're multiple. Unlike the last case, they're low density. They're not vascular, and they're also multiple. So what could it be? Well, polyposis syndromes. But there the polyps are usually more solid, and they are multiple. I don't see anything else in the scan, though I only gave you a limited part of the scan. Here's a few more images in the coronal views, and you really get a very nice look at those polypoid lesions. And if I give you cinematic, you can see them standing out against the water. So one thing to remind you again, it's very important to give water to distend the stomach. If you distend the stomach, you can pick up polyps, whether it's single or multiple. If you have multiple polyps, what are you thinking about? Again, polyposis syndromes come to mind, multiple adenomas come to mind, carcinoid tumors would come to mind if these were vascular, and they're not. And there are benign polyps. There's an entity called Fundic gland polyps, and that indeed, if I go back, that's the answer. Fundic gland polyps are uncommon, and interestingly, current guidelines do not recommend polypectomy or surveillance endoscopy for sporadic cases. If you do find multiple fundic gland polyps in a younger patient or a polyp with dysplasia, then you need to investigate to see if the patient has a process like FAP, familial adenomatous polyposis. What a great case. Another stomach case, big bulky tumor of the stomach. There's adenopathy by the celiac, and there's ascites best seen around the liver. Bulky tumors, yes, adenocarcinoma, yes, lymphoma, just is usually not infiltrating. Metastatic disease like linitis plastica, but this is sort of too bulky for that. Then when I look at the coronal images, look by the heart, you see large paracardiac nodes, you see large mesenteric and periaortic nodes. Now, you can get adenopathy with lymphoma, obviously, adenopathy with adenocarcinoma. Adenocarcinoma, classically, the nodes only extend to the renal hilum. Here it goes beneath the renal hilum. Also, those pericardiac nodes, to me, I always am thinking about lymphoma or maybe Mets, melanoma, but melanoma can give you large eccentric masses that do look like just tumors. It can give you polypoid lesions that look like carcinoma, but it'll be a strange appearance. And so the best diagnosis, if I ask you in this case, is going to be a B-cell lymphoma. Really nice bulky tumor and really nice adenopathy. Really good example. Okay, another case. Stomach again. Acute abdomen. You can blow by this, but if you look carefully at the posterior gastric wall, there's literally wall thickening and there's an ulcer present. I just want to make the point how subtle it is. It's a good example by looking at the sagittal, things are more obvious. You see an ulceration, you see thickening of the posterior gastric wall. Now, benign versus malignant, if the ulcer's big and irregular, if the mass is bigger and bulkier, you would tend to favor malignancy over benign. And whether something perforates or not is not going to help you typically. I don't see any distant adenopathy. I don't see liver mets, obviously, things that would help you go with malignant, but very nicely showing you the lesion. And then let's go a bit further, and I'll show it to you as cinematic. Now look how nicely you can see we're looking into the stomach as if we're inside the body of the stomach. You see the posterior ulceration, the diffuse wall thickening. And again, you make your consideration. This patient will end up with endoscopy, and this was a benign gastric ulcer. Beautiful example of an ulcer, beautifully shown on the cinematic rendering. Just a really, really nice example. Okay, what about this patient with back pain? Bilateral adrenal masses, non-contrast. It's not low density like adenomas. It could be mets, obviously. Melanoma, hepatoma, almost anything. Lung cancer. Could be theos. There's no IV contrast, nothing's enhancing. Could it be ACC, primary adrenal cortical carcinoma? Rarely, only about 2% are bilateral, and surely not at this size typically. When you give contrast, the lesion enhances, but it's not hypervascular like theo, so forget that. Could be mets. It's not adenomas, it's not bilateral myelipomas. Well, what are we thinking about? You gotta also remember, and I did not say it, but I knew the answer, is what about lymphoma? Lymphoma, typically bilateral, typically bulky. This is actually small for lymphoma. Primary lymphoma is when there's involvement of the adrenals, but no extra adrenal involvement. You can see we don't see adenopathy, we don't see anything else. Nice soft tissue infiltration. Very nice example when you look at those images of lymphoma. Again, I've had a few cases recently, but they're big and bulky, not looking like this. Okay, another case. Abdominal discomfort. There's a mass in the root of the mesentery that's partially calcified. It comes near the vessels. Now, what am I thinking of? Mass in the mesentery, carcinoid tumor, sclerosing mesenteritis, calcified nodes from TB, calcified nodes from lymphoma. Castleman's disease can calcify occasionally, but not like this. Now, the differential between carcinoid and sclerosing mesenteritis can be difficult. One thing that helps is with carcinoid, there's more of this plastic reaction around the vessels. Here the vessels, if you look at the next image, look fairly smooth. You don't see that really regular and beating of the vessels. You don't see that really bad desmoplastic reaction. So in this case, I would favor sclerosing mesenteritis, which was the correct answer. We spoke about this yesterday in conference. Steve Rowe made the point, we were asking about dotatate scans with neuroendocrine tumors like carcinoid being super hot. He did mention sclerosing mesenteritis can have increased uptake, as any inflammatory process can, but it's not the intensity of carcinoid. So nuke studies can be helpful in that regard. Okay, another patient, left upper quadrant pain. This is a low density mass. It almost looks a little less dense than water, but it's well defined and it's pushing stuff. It pushes the pancreas, it pushes the spleen, it pushes the stomach. I'll give it to you again. You can see it here. It's pushing everything, filling in the space. This is not going to be a malignancy. This is not a solid mass. This is a soft mass that's pushing on stuff. Could it be a cyst like a pseudocyst? I guess it can, but it would be kind of funny looking. What else could it be? What gives you soft tissue masses? Hemangiomas? Okay, not that. That's vascular. Lymphoma? But again, that's solid. What things can do it? Well, one of them is lymphoceles, right? We talk about mesenteric cysts, but they're better defined. They don't interweave into everything. The thing that interweaves, that also begins with the L word, is lymphangioma. Beautiful example of lymphangioma infiltrating the left upper quadrant, pushing spleen, stomach, liver, and kidney. Benign lesion will often be resected because it causes discomfort, but there's no malignant potential. Okay, we're getting near the end here. I think I have 2 more cases or 3 cases. What about this one? Patient has right lower quadrant pain, there's ascites, and there's diffuse wall thickening of the terminal ileum. You can see it very nicely here as well. This is not appendicitis. Could it be Crohn's? Boy, it's bulky. If this is Crohn's, I'm thinking Crohn's with cancer. Could it be TB, other inflammatory? I guess you could think of that. You have ascites. But when you look at it more carefully and you look at the coronals, it's really an infiltrating process of the ileum. Again, I'm not going to think about Crohn's because it's too bulky. I could think about adenocarcinoma. I could think about lymphoma. I could think about metastasis. Ischemia, vessels look good. It doesn't really quite look like ischemia. Here it is on the cinematic. You see the lumen. You see the wall thickening right to the terminal ileum, ileocecal valve level. That location, adenocarcinoma versus lymphoma. Things that occur and involve the cecum across the ileum are more likely going to be lymphoma. And this was a B-cell lymphoma. A really good case. Okay, what about this case? Suspected pancreatic cancer. There's a large mass in the region of the pancreas, but there's no dilated ducts. It's bulky. And the question is, where is it? Well, it's either arising from or near the duodenum. What do we see in this region? I've shown you cases of large GIST tumors. I've showed you neuroendocrine tumors, but this is not vascular. I've showed you metastases, but these are not discrete nodes like from right-sided colon cancer. GIST tumor is not a bad thing. Big mass pushing things, not obstructing. GISTs are common in the duodenum, and they're mildly vascular, not typically hypervascular. But the other thing I've seen probably half a dozen times in this region are metastases, and the Mets are from melanoma. Often the patient doesn't know they have a history of melanoma, and they present with this big bulky mass, and it's worked up as a pancreatic tumor for the obvious reasons. On biopsy, you get the report back, it's metastatic melanoma. New chemotherapy agents, checkpoint inhibitors, the patient should do well. But again, key is the diagnosis, and that was metastatic melanoma to the duodenum. Just a wonderful, wonderful case. All right, let me give you one more, since you've been really nice, audience. Incidental findings, cystic lesion tail of pancreas, thickened rim with some enhancement. It's not going to be a simple cyst like a pseudocyst. It's not going to be an IPMN unless this was an IPMN with malignancy. That would be a possibility. It's not a serous cystadenoma. It doesn't have the enhancement and nodularity makes me aim away from that diagnosis. You can particularly see the rim enhancement and thickening on the coronal and 3D volume rendering. And you could see that again also on the cinematic rendering where the wall is particularly well seen. So now you say to yourself, cystic lesion tail of pancreas, wall thickening. Okay, mucinous cystic neoplasm, yes. IPMN with malignant dysplasia, yes, but it's too much symmetric thickening. It's not your typical eccentric nodular lobular thickening. But we always got to think about neuroendocrine tumors. We've talked about how neuroendocrine tumors of the pancreas are typically hypervascular, but also that they're sometimes hypovascular. They commonly calcify, but they also can be cystic. They're cystic with a thickened, enhancing rim with often nodularity. So this case, my friends, was a cystic neuroendocrine tumor. So that's my last case for you today. Those were 10, I think, terrific cases. Today is the 20th of April. I hope you have a great day, and I hope you have a great week, and I hope you have a great month. And with that, take care, everybody.